What's up, Ninja Nerds? In this video today, we're going to be talking about hypoparathyroidism. But before we get started, if you guys like this video, you enjoy it, it makes sense, you benefit from it, please, the best way that you truly can support us is by hitting that like button, commenting down in the comment section, but most importantly, subscribe. Also, if you guys really want some great notes, and I mean awesome notes, amazing illustrations that you guys can follow along with me throughout the process of this lecture to really cement that information into those deep cerebral cortex neurons, then please go down in the description box below. We'll have a link to our website where you guys can go check that out. All right, let's start talking about hypoparathyroidism. All right, so let's start talking about hypoparathyroidism. Before we actually do that, we have to have a little understanding of physiology. It'll truly make sense of a lot of the causes, pathophys, diagnosis, and even the treatment of hypoparathyroidism, because once we go through this pathway, it's really just kind of looking at what happens when parathyroid hormone levels are low. All right, so first things first, where is parathyroid hormone made? It's made by the parathyroid glands, right? And so the parathyroid glands are located in the back of the thyroid gland. There are these tiny little baby glands on the back of them. And the parathyroid glands are responsible for making what we're gonna abbreviate here, parathyroid hormone, PTH. Now, if we were actually to truly look at the parathyroid hormone, where it's actually secreted at the cellular level, we actually dissect, we get down, nitty-gritty, and we look at the different cells that are responsible for making PTH. Those beautiful cells here are called your chief cells. So these chief cells, they be blasting out that PTH, right? They're the ones that are responsible for making PTH. Now, you have to ask the question, what are the things that can really trigger the PTH production, right? Because that's important. So in these patients who have hypoparathyroidism, we'll talk about some of the things that can affect this process, but in general, the things that stimulate PTH is whenever somebody's calcium levels are low, whenever phosphate levels are high, and whenever your vitamin D levels are low. These seem to be stimuli for PTH production, so remember that. Now, what does PTH do? What target organs does it work on? How does it work on those target organs? That's an important thing to think about, right? So PTH loves to act on the bones. When it acts on the bones, it acts on very specialized, cute little cells in the bone tissue. And these cells are called osteoblasts, or one of them. And the osteoblasts, which are going to be this one right here, this is a bone building cell. It's mainly designed for bone deposition, putting calcium, putting phosphates, putting hydroxyapatite molecules into the bone to build it up. The other type of cell here is called an osteoclast. Now, osteoclasts are bone destroying cells. They want to do what's called bone resorption. They want to yank calcium, yank phosphate, yank different types of hydroxyapatites out of the bone tissue to enable what's called bone resorption. So, in this process, PTH actually acts on osteoblasts. When they act on osteoblasts, they stimulate osteoblasts to make a very special molecule called rank ligand. Rank ligand will act on these little rank receptors, They act on these rank receptors located on osteoclasts and stimulate them. And osteoclasts, in response to that, start secreting certain types of nasty digestive enzymes that help to start wearing or resorbing or demineralizing calcium and phosphate away from the bone. So what would that look like? If we came down here for a second, what would you see is that osteoclasts would start releasing some of these molecules, and in the process, we would start leaching what? Calcium and phosphate from the bone. That would be the whole function here. So it would liberate calcium, liberate phosphates into the bloodstream. That's the whole significance there. Okay. That's one of the functions. Now, if we go up and see what else it does, PTH also loves to act on the kidneys. And when it acts on the kidneys, it stimulates the kidneys to increase the expression of a very cute little enzyme. And this enzyme here is called alpha-1 hydroxylase. You're like, man, what the heck this got to do with it? I got you, boys. All right, so here we go. Alpha-1 hydroxylase is a very cool enzyme. You know there's a molecule that's made by our skin constantly, and this molecule that's made by our skin is called 25-hydroxycholecalciferol. Look how juicy that orange is. That look good. So that molecule that's made by the skin gets acted on by this enzyme, alpha-1 hydroxylase. And all it does is it puts a hydroxyl group on the one carbon. So that makes this 1,25 dihydroxycholecalciferol. You're like, Zach, what does this have to do with anything? This right here, this molecule is called active vitamin D. So vitamin D is important because it plays a huge role within the calcium absorption process. How? I got you. It works here on the gastrointestinal tract. You know, within the GIT, You know, vitamin D is kind of like a steroid hormone molecule, so it can actually just move right into the cell. When it moves into the cell, it activates like intracellular receptors, if you will, activates certain types of genes and transcribes them, translates them. And what will happen out of this is that I'm going to make these proteins that get embedded into the cell membrane of the GIT, particularly within the small intestine, because that's where absorption really takes place. And what I'm going to do is I'm going to have lots of calcium that's going to be flowing through my gastrointestinal tract. When vitamin D is present, it's going to increase the expression of these proteins that weren't there previously. And the end result is we're going to bring calcium across the GI tract into the blood. Effectively, what will this do to the calcium inside of the bloodstream? It'll increase the calcium. So you're starting to see a trend here that PTH particularly likes to increase your calcium levels in the blood. Okay, that's another function. Another function that PTH also can do is really cool here. It can act on the kidneys, not just to increase the expression of this enzyme, but it also tells the kidneys to do something else. So what I want to do is I want to take a piece of this actual kidney, what's called the nephron, and zoom in on it in a blown up view. And this is what we're going to get here. So when we do that here, we got this cool little cute nephron, and PTH acts on two particular cells within the nephron. The cells of the distal convoluted tubule and the cells of the proximal convoluted tubule. This one and this one, right? So this would be your Bowman's capsule. This would be the proximal convoluted tubule, loop of Henle, distal convoluted tubule, and collecting duct. Yeah? What parathyroid hormone does is it acts on particular channels in two areas here, in this proximal convoluted tubule and the distal convoluted tubule. When it acts on the receptors here in the proximal convoluted tubule, PTH actually works to inhibit this channel in the proximal convoluted tubule, and PTH stimulates this channel in the distal convoluted tubule. So that begs the question, what do these channels do? Don't worry, I got you. PTH inhibits this channel, and this channel normally wants to bring sodium and bring phosphates absorbed across the proximal convoluted tubule into the blood. If PTH inhibits this process, you will not be able to reabsorb these molecules. So they'll end up in the urine. You'll pee them out. And so effectively, you're going to pee phosphates out into the urine because PTH is going to inhibit that process. You know, another name for PTH is phosphate trashing hormone. I'm just kidding, but it makes sense, right? Because it's going to excrete the phosphate. So it lowers the phosphate at the same time as it increases the calcium. All right, so that's one thing. The other thing is in the distal convoluted tubule, it reabsorbs calcium and it excretes phosphates. That's its job. So if it stimulates this channel and it's working, it'll start excreting more phosphate into the urine. But if it also is stimulating this channel, it'll bring more calcium into the bloodstream. So effectively, it increases the calcium within the bloodstream, but decreases the phosphate within the blood and increases the phosphate within the urine. Okay? And in the process, what else did it do? It also increased the expression of what's called alpha-1 hydroxylase. And what did that enzyme do? That enzyme helped to increase the activation of a very specific molecule that worked here in the GIT, which was vitamin D. So it stimulated the activation of active vitamin D. So these are the generalized functions of what? Of PTH. It's designing to increase your calcium within the blood, and it liberates phosphate from the bone, but that phosphate gets excreted, lowering the phosphate within the blood, increasing the expression of this enzyme that increases vitamin D, and vitamin D increases calcium absorption. We got the physiology down. Guess what? All we got to do for the causes in pathophys and think about what happens when this pathway is decreased. So let's go do that. All right, so let's talk about the causes and pathophysiology of hypoparathyroidism. It actually should be pretty straightforward. So in hypoparathyroidism, we have to think about the cause. It's the parathyroid gland is just not working. It's not functioning, and it's not releasing any PTH, or if it is, it's releasing very little. But there's one other type that we'll mention a little bit later, which is a type of pseudo hypoparathyroidism, where it actually PTH production could be normal, maybe even a little bit high, but that the receptors that respond to PTH aren't working. And so we'll talk about that one as well. But for the most part, I want you guys to kind of nail it down to causes of hypoparathyroidism, or something is wrong with the parathyroid where it isn't making PTH. What would be an easy reason? you don't have parathyroid glands. So someone had a thyroid surgery, incidentally took out a parathyroid gland, or they had hyperparathyroidism and they had to get them removed. So some type of surgical removal of the parathyroid glands, or maybe it's not even just surgical removal like a parathyroidectomy or incidentally removed during a thyroidectomy. Maybe there was some type of radiation therapy. You're getting some type of significant radiation therapy within the neck region for something else. So it doesn't have to just be surgical, but it also could just be not surgical, but extensive radiation therapy, maybe that you were receiving for some type of process within the neck region. All right, but that's simple. If you have that issue and you're destroying the parathyroid glands due to surgically removing them or destroying them from radiation, their PTH production is going to be dookie. So they'll have less PTH production. Pretty straightforward, right? It's nothing crazy there. The other one that I want you to think about is where the actual parathyroid glands don't form properly or they don't form at all. This could be an embryological issue. So there's an embryological condition, if you guys remember from the, the pharyngeal apparatus lecture within our embryology playlist, there's a condition called Dye-George syndrome. So we call this Dye-George syndrome. And in Dye-George syndrome, there is the inadequate development, or you don't form, the third and fourth pharyngeal pouch don't completely develop. And so again, which one is it? The third and fourth pharyngeal pouch don't properly develop. And if they don't properly develop, you have to remember that the third and fourth pharyngeal pouch are important for being able to lead to the development of certain structures, such as the parathyroid gland, such as certain types of large output vessels from the actual heart, as well as the thymus. So in a patient with Dye-George syndrome, if they present this on the clinical vignette, where a patient has hypoparathyroidism, right, due to inadequate development of the parathyroid hormone and parathyroid gland, this could lead to a reduction in PTH production. They may also have abnormalities of the cardiac outlets, so they may have some type of cardiac abnormality. And last but not least is they may have no thymus. And they may have immunological abnormalities that puts them at a higher risk of infection in a younger age. So these are things to think about, and this is usually due to a chromosomal abnormality where there is an inadequate development or you don't develop that third and fourth pharyngeal pouch, which doesn't lead to a proper parathyroid gland, large output vessels from the heart, as well as a thymus. All right, beautiful. So we have you remove it, you radiate it, or you don't form it. Another thing is that, this one's a little interesting, it's an autoimmune condition, okay? But this autoimmune condition that people usually develop that can cause damage to the parathyroid glands, it rarely does it ever just occur with the parathyroid gland itself. It usually affects other tissues. The other tissues that commonly get affected from this immunological process is the adrenal cortex and the skin. In this condition where your immune system is producing autoantibodies against its own tissue, it seems to be producing it against multiple different types of endocrine glands. This condition is called autoimmune polyendocrine syndrome type 1. So what is this condition called? It's called autoimmune polyendocrine syndrome type 1. Obviously, there's another type, but we're not going to talk about that one. Now, what I want you to remember for autoimmune polyendocrine syndrome type 1 is that this is the second most common cause of hypoparathyroidism. The first most common cause is surgical removal or some type of radiation therapy to the parathyroids. But again, if you have a clinical vignette for this one, the patient will not only have low parathyroid hormone, but they may also have adrenal failure. So they may have signs of adrenal failure. In other words, they may have a reduction in cortisol, a reduction in aldosterone. And so they may have certain types of adrenal crises. And last but not least, they have involvement of the skin to the point where it leads to what's called chronic mucocutaneous candidiasis. It's a heck of a thing here, so let's actually write that down. It's called chronic mucocutaneous candidiasis. So this is a common type of triad that you would want to remember for the autoimmune polyendocrine syndrome type 1. Is it's the second most common cause, and it usually involves the parathyroid gland, adrenal gland, and the skin with the condition called chronic mucocutaneous candidiasis. Boom, roasted. Let's move on to the next one. The next one is you either, again, remove it, don't form it, destroy it, or you infiltrate it with multiple different types of molecules or chemicals, to the point where you infiltrate it and deposit so much molecules in there that it depletes the function of these parathyroid glands. What would that be? So we want to think about what's called infiltrative diseases. So infiltrative diseases. And there's really two that may come up in your head. One, sometimes people think about sarcoidosis. Sarcoidosis could potentially do this, but it's not too common. There's actually two diseases. One is where you deposit lots of what's called copper into the parathyroid gland, and another one is where you deposit lots of iron into the parathyroid gland. So if you're depositing lots of copper or depositing lots of iron into the parathyroid glands, it'll eventually cause them to become reduced in function to where the parathyroid hormone production starts reducing. What is the condition called where you have copper overload and iron overload within the body? Copper overload is due to a condition called Wilson's disease. And the iron accumulation is called hemochromatosis. Okay? So we have so far, you remove it, you don't form it, you cause autoimmune destruction of it, or you infiltrate it with certain types of ions like copper and iron. So this next one is actually high yield, and you actually do need to know it, even though it's not a true cause of hypoparathyroidism. So this condition here is called pseudo hypoparathyroidism type 1A, also known as Albright's syndrome. Now, in this condition, what I want you to know is that it is an autosomal dominant type of condition where they lead to an abnormal, a mutant expression of a very specific type of molecule that codes for the G stimulator protein. Okay, so there's a specific gene that codes for what's called the G stimulatory protein. Now, why is that important? Okay, in this condition, if you don't have this mutant G stimulatory protein, that can become an issue. Here's why. Let's say that you have no issue with your parathyroid gland. Okay, no issue. So your parathyroid gland are actually releasing what type of molecules? They're releasing PTH. Here's where it's a little interesting though. If you look at the actual cells that we said respond to PTH within the kidneys. So let's say that we were to just kind of like zoom in on a kidney cell here. And if we were to zoom in on one of those actual bone cells via the osteoblasts, they should have special types of receptors on them, right? They should have special types of receptors that respond to the PTH. Now, if you guys remember anything from your cell physiology stuff, is that if we were to take a cell here and you have a receptor and a chemical such as PTH binds to that receptor, it should activate this receptor, which will then stimulate what's called a G stimulatory protein. G stimulatory protein will then activate a molecule called adenylate cyclase. Adenylate cyclase will then stimulate what's called, convert ATP into cyclic AMP. And cyclic AMP will be the intracellular second messenger molecule that will kind of cause an increase in cellular activity or function. In a patient who has pseudo-hypoparathyroidism type 1A, there is a mutation or a defect in this gene that codes for that G stimulatory protein. So guess what? PTH will try to bind to the cells, the receptors on the kidney, and bind to the receptors within the bone tissue to try to exert its activity to increase the cyclic AMP and cause all of the functions that we talked about. But if this G stimulatory protein is not functional, It won't be able to activate adenylate cyclase. It won't be able to activate cyclic AMP, and the function on these target organs becomes diminished. And so what would happen as a result of this? Would your bone tissue reabsorb any types of calcium or phosphate? No. And so out of this process here, you don't do that. And so this could lead to hypocalcemia. Will you be able to excrete phosphates into the urine? No, because PTH can't respond here. And so the phosphates will end up lower in the urine and higher within the bloodstream. And will you be able to reabsorb calcium across the kidneys? No. So calcium levels will lower. Will you be able to activate vitamin D if PTH can't respond, if there's no response to PTH here? No. And so there'll be a reduction in active vitamin D. You get the whole point here. If there's less vitamin D, you absorb less calcium. So it can make it look weird as though someone has hypocalcemia, hyperphosphatemia, but in their PTH levels could be somewhere from normal to even high, because this low calcium, what will it do? Low calcium is going to go and do what? It's going to go tell your parathyroid glands, hey, calcium's low, guys. Start making more PTH, and you'll make more PTH. So sometimes the PTH levels can be from normal to high, but the PTH isn't exerting its effect. And so you get this kind of picture of hypocalcemia and hyperphosphatemia that can maybe think like, oh, this could be a hypoparathyroidism. So it's a pseudo hypoparathyroidism due to the inactivity or inactive response to PTH. Okay. What I do want you to take away from this one is that these patients usually present with a very specific type of clinical syndrome. And that clinical syndrome that they usually present with is they can present with obesity, they present with intellectual disability, they present with what's called a short stature. But here's the high yield point. They have a fourth and fifth digit that is very shortened. So they have what's called shortening or brachydactyly of the fourth and fifth digits. So these are things to remember for these patients with pseudo hypoparathyroidism type 1A, is this whole process we talked about, plus obesity, intellectual disability, short stature, and fourth and fifth digit shortening. Okay, last one here. This last one here is called idiopathic. Okay, this is the idiopathic type of cause of hypoparathyroidism. So this is an interesting one. So there may be some genetic relationship here, but what we know is that the parathyroid glands, they have a small reduction in PTH. But the reason why is that if we actually take the cells that are making the parathyroid hormone, these chief cells, remember these guys? The chief cells have a very special type of receptor on them called a calcium-sensitive receptor. And what the calcium-sensitive receptor does is whenever calcium levels are high, what would it do? If calcium levels are high, it would activate this receptor and tell them, hey, calcium levels are too high, you gotta chill out with the PTH. You gotta lower the PTH. We don't want to keep producing PTH. Well, imagine if this calcium-sensitive receptor was mutated in a way that it was always hyperactive, pretty much simulating as though there was always high calcium levels. That is this idiopathic condition, which may have some type of genetic relationship here. And so in this patient with idiopathic hypoparathyroidism, there may be an increase in the activity of the calcium-sensitive receptor. And if this is in kind of this active state, it'll continue to present as though there is a hypercalcemic state and consistently lower the parathyroid hormone. All right, that covers our causes in this aspect. Let's now continue to move on to talk about how these things can lead to low PTH. And then whenever there is low PTH, what are the clinical features associated with it? All right, so let's continue on. So we have a patient now that we know is making less parathyroid hormone. And again, it could be due to surgical removal. It could be due to radiation. It could be due to because D didn't form it. It could be due to an autoimmune type of infiltration. It could be due to infiltrative diseases due to copper, iron. It could be due to an idiopathic situation where the calcium-sensitive receptor is hypersensitive. Or it could be pseudo-hypoparathyroidism where the PTH receptors aren't responding. And that's not a true hypoparathyroidism. Okay, if we're making less PTH, what would that look like? Okay, let's think about this. Less PTH, less activity on the bone, right? So less osteoclastic activity. That means less calcium is being liberated from the bone and less phosphate levels are being liberated from the bone. So effectively, this will cause hypocalcemia and lower the phosphate levels within the blood. But again, if the kidneys are working, we'll see how this can change a little bit. Okay, next thing, that's one point. Second thing is it acts on the kidneys, right? Less PTH means that you get less activation or less formation of what's called 1-alpha hydroxylase. If there's less activity of this enzyme, what do you make less of? There's a reduction in active vitamin D. If there's a reduction in active vitamin D, you don't absorb calcium across the GIT properly. And so if you're not absorbing calcium across the GIT, what's the overall effect here? Hypocalcemia and decreased active vitamin D. Next thing, if you're not working properly on the kidneys, are the kidneys still responsive? Yeah, they're good, but you don't have a lot of PTH. If you don't have a lot of PTH, remember what it does to the kidneys? It excretes phosphates. If there's less PTH, will you excrete the phosphates? No. And so the phosphates will actually not be excreted into the urine as properly because again, PTH, phosphate trashing hormone, right? If it's less of it, you're not going to trash as much phosphate. So what happens to the phosphate level truly within the blood? Technically, the phosphate levels within the blood will go up because you're not going to be excreting it. Also, PTH acts on the kidneys to reabsorb calcium and excrete phosphate. We already know that we're not excreting phosphate, so will we reabsorb calcium? No. And so because of that, the calcium levels will be low. So what could we surmise from that diagnostic-wise? It's pretty easy, right? And we'll see that in a second that these patients will have low PTH, high phosphate, low calcium, low 1-alpha hydroxylase, and low vitamin D that's activated in that form. Now, the big two things that I really care about here is this low calcium and high phosphates. These are the things that are actually going to produce a lot of negative side effects upon the body, potentially. So what are those things? Well, the first thing that I want you guys to think about is how it alters the activity of neurons. Do you guys remember what I said about calcium around those sodium channels of different excitable cells like neurons and smooth muscles and cardiac muscle? Remember the calcium wraps around these sodium channels? Okay? So there should normally be a little bit of calcium there. But in someone who has hypocalcemia, there's less of this calcium there. And so less of this calcium means less of these positive ions around the center or area of the sodium channels. If there's less positive ions, there's less repulsion. So if there's less repulsion, that means, guess what, baby? Sodium is going to flood right in. And he's going to be like, hold on, baby, I'm home. And the positive ions will start soaking up into these excitable cells. If it increases the positive charge within these cells, it's going to increase the electrical activity, increase the action potentials, and increase the activity of excitable cells. So that is the big thing that I want you guys to remember, is that with this lower calcium, there is less sodium blocking effect, less sodium blocking in these excitable cells. Now, think about how that comes into play. If the neurons are hyperactive, they're working harder, they're being more hyperstimulated, what would that do to the clinical presentation? All right, so if these neurons are hyperexcitable and they're firing, what kind of condition would be somewhat similar where a patient's brain is just on fire, excessively synchronous firing of the neurons to where they start developing these types of movements? Seizures, right? So this can actually get to the point where it can actually cause someone to develop seizures. Now, that's one thing. The second thing that you want to remember is, what if it also causes your mental status, your actual mental state to become hyperactive? Then you're just like irritable, you're anxious, and you're at the point of delirium, right? And so they can develop even to the degree of hallucinations. And so this could be another thing, mental status-wise, they could be irritable, they could develop psychosis, to the point where they even develop like hallucinations, and maybe, again, not only this kind of situation here, but maybe even the degree of delirium as well. Now, that's one thing. Here's another one. Here's where it gets even cooler. These firing of neurons is, again, pretty excessive. What if I were to take and check someone's reflexes? And I tapped on that actual patellar tendon, caused the sensory reflex, but these neurons are on hyperdrive. It's going to cause that motor neuron to just fire out and whoop. They're going to have hyperreflexia. And so they can have an increase in their deep tendon reflexes. What else? Another thing here is that these nerves and muscles are so excitable that you could tap a nerve, literally tap near like a nerve. You know the facial nerve runs here in this area near the parotid gland? If you tap about 2 centimeters anterior to the earlobe and you just tap here, it can actually cause that facial nerve to become so excited that it causes like facial twitching on that same side. You know what that's called? It's called sign. Okay, and I'll just put here just so you remember it, this is going to be the facial nerve. Okay, so you're kind of like hyper-excitable, that actual facial nerve. Now, another situation is where these nerves are so hyperactive, where not only if you tap it, what if you were to actually use a blood pressure cuff, inflate up someone's arm to where it actually was compressing down on the nerves that are running down to like the actual forearm or wrist area? You know what happens when you actually inflate a blood pressure cuff? And these patients with hypoparathyroidism, due to having this hypocalcemia, they actually inflate the cuff, and as they inflate the cuff, their wrist starts flexing, and so do their fingers. And this causes a carpopedal spasm. So it's a carpopedal spasm, but this can be induced. And when it's induced by the blood pressure cuff, this is called Trousseau's sign. Okay? There's one other thing that could happen. Not only could there be, again, an increase in deep tendon reflexes, increase in the hyperexcitability of neurons via Schaaf's sign or Trousseau's sign, but also, you know, it alters some of the sensory neurons as well. So the sensory neurons can actually be altered in a way to where it can actually cause paresthesias. And you know what's the common presentation? Is they develop numbness, tingling, certain types of burning pain around the lips. Circumoral paresthesias or circumoral numbness. And so they can develop paresthesias, especially circumoral is a very common location. These are the big signs that I really want you to remember. 2 big ones here is the Trousseau's sign and the Schaaf's sign. Please don't forget those, okay? Here's something else that's really interesting, and I thought this was so cool. You can actually worsen, so this whole kind of process here, where these patients are having this hyperexcitable neurons, this is kind of a collective condition here, if you want to think about it. This whole thing here is actually collectively called tetany. We can actually like reproduce this tetany, these types of responses, and make it worse in a very interesting process. Watch how this happens. In someone who is hyperventilating, they're breathing faster, they're breathing at a higher respiratory rate and maybe even depth. When you're hyperventilating, what are you doing with respect to CO2? So if you're hyperventilating, you're increasing your respiratory rate and depth. You're going to blow off, more CO2 is going to get removed, yeah? Now when you remove more CO2, what does that do to the CO2 within the bloodstream? It'll lower the CO2 within the bloodstream. When you lower CO2, that lowers the amount of protons within the bloodstream. If I lower protons within the bloodstream, that is going to increase my pH. You're probably like, what in the world does this have anything to do with this? Here's why. You know albumin, this cute little protein here? Albumin is negatively charged. So imagine it has negative charges all over it. Now, when you have a pH that's more alkaline, meaning that there's less protons, these actual albumin molecules have negative charges that are supposed to bind these protons. But if the pH is higher, there's less of these protons. That means that there's less of these protons that need to bind with the albumin, the negative charge of the albumin. That leaves more negatively charged sites open. If more negatively charged sites are open, guess who will go ahead and bind to those negatively charged sites? Calcium, because calcium is positively charged. If calcium is positively charged and it binds with all of these negative charges that are open now on the albumin because there's less of these protons, we soak up the calcium onto albumin. What does that do to the free calcium levels? It decreases the amount of free or ionized calcium. And that precipitates a worsening of the patient's hypocalcemia and can worsen these types of symptoms. So this is called hyperventilation-induced tetany. It's a high yield fact that may come up on your actual step exam. Okay, last thing here, super quick ones. I don't want to go too crazy on these, but other types of things that can happen is that you can develop calcification sometimes, or issues where sometimes there can be issues with the calcium deposition process. And sometimes when this calcium can actually kind of deposit within certain tissues, especially within the central nervous system, this may lead to a couple different things here where you can have what's called extrapyramidal symptoms. So sometimes this alters, again, the calcium kind of deposition process within the brain tissue, especially in the area of the basal ganglia. And so they can develop kind of like Parkinson-like symptoms, bradykinesia, they can develop rigidity, they can develop athetosis, dystonia, things of that nature. It can alter the deposition process within the lens to the point where it can actually lead to cataracts. And the last thing, again, I tried to look and find where and how it actually does this, and I couldn't particularly find it, but something to remember is that there's what's called the QT interval. And this is a very high yield fact for your actual exams, is that in patients with hypocalcemia, their QT interval tends to be longer. They tend to have a prolonged QT interval. And if you have a prolonged QT interval, what does that prolonged QT interval put you at risk of? It increases the risk of what's called torsades de pointes, okay, which is a fatal arrhythmia. So that's something to consider. And again, that covers all of the pathophysiology and causes and clinical features. Let's now hit it home quickly with the diagnosis and treatment. All right, engineers, you didn't miss anything. I just wanted to quick get ahead, and I wanted to kind of redraw out for this diagnosis part everything that we kind of cover within the pathophys, so we don't have to kind of waste any time. Let's be efficient, right? So to cover the diagnosis of someone with hypoparathyroidism, what should we think about? Well, think about it again. What's the problem? The parathyroid gland isn't making PTH, or it's making very little of it. So low parathyroid hormone. That right there is going to be one of the diagnostic values that you'd want to check. Check their PTH. If it's low, it could be indicative of hypoparathyroidism. Okay, because of them having low parathyroid, remember they act on the bones first. That was within our first diagram. If there's less of the PTH, that means less calcium is liberated from the bone. Now, less phosphate is liberated from the bone, but that doesn't mean that there's actually low phosphates in the blood. Why? We'll explain in just a second. Again, low levels of PTH, remember it acts on the kidneys. When it acts on the kidneys, it's supposed to increase the expression of alpha-1 hydroxylase. Well, there's less PTH. That means less expression of this alpha-1 hydroxylase. So if you were to by chance check this enzyme, that would be lower. If there's less concentration of this enzyme, that means that you activate less vitamin D. And so there can be decreased concentrations of the active vitamin D. If there's less vitamin D that's active, it's going to absorb less calcium across the GIT into the blood, again, exacerbating the hypocalcemia. Again, PTH acts on the kidneys not just to increase the expression of this enzyme, but it also acts on the kidneys to reabsorb calcium and trash out or excrete phosphates. If there's less PTH, can it reabsorb calcium? No. And because of that, again, this exacerbates the patient's hypocalcemia. Can it excrete phosphates? No. And so you have less phosphates that are going to be present within the urine and higher levels of phosphate within the blood. These are things to think about. So in these patients, they would have low PTH, low calcium, high phosphates, low levels of alpha-1 hydroxylase, and low levels of active vitamin D. All right, let's hit it home with the treatment of hypoparathyroidism. All right, so let's think about this, guys. We have a patient now who has primary hypoparathyroidism. What could be a way that we could treat this? We could give them PTH, right? So giving the patient parathyroid hormone because they aren't able to make any parathyroid hormone could be one of the ways of alleviating this process. Because if we were to increase their PTH by giving them recombinant PTH, that would work to be able to increase calcium, excrete phosphates, increase the expression of active vitamin D, right? So it makes sense, giving them PTH. You prefer to do this after you've tried other things like calcium and vitamin D supplementation. So if you've been giving somebody calcium and giving somebody vitamin D and they're still not being able to get their levels at the appropriate portion that they want, or they're taking extremely high doses, you can consider recombinant PTH. Now, last but not least, the problem here that we talked about is this low calcium, this hypocalcemia. In patients with this severe hypocalcemia, what can we do? Well, we could obviously give them PTH, or we could replace the calcium. So giving them calcium within their diet, giving them calcium supplementation, and giving them vitamin D supplementation. The last thing to think about here is that there was also an issue with high phosphates. If there's high phosphates, what else could we potentially do to lower those levels of phosphates? We could try to eliminate phosphate through another source rather than the kidneys. We could eliminate it through the feces. And so one of the ways that we can do that is we give a particular drug that helps to excrete phosphate via the stool. And this drug that will actually work by, let's imagine here is this drug, and it has positive charges on it. And let's imagine here I draw in red phosphate. It'll bind to these phosphate molecules and poop them out. This drug here is called sevelamer chloride. And this is one drug that we could do to get rid of the phosphates. The other thing we could do is just restrict phosphates in the diet. Okay? But it's a very simple concept. It's not too hard to think about the treatment. If they can't bring their calcium up with calcium and vitamin D supplements, if you can't get rid of the phosphates via the sevelamer and restricting phosphate, consider adding on recombinant PTH. All right, my friends, that covers hypoparathyroidism. I hope it made sense. I hope that you guys enjoyed it. And as always, until next time.